Welcome back to Therani, I'm Joe B. Today I'll show you how to reduce or eliminate hip impingement pain through joint distraction. Let's dive in. Femoroacetabular impingement or hip impingement occurs when the femur and acetabulum do not fit together accurately. The exact cause is unknown, but the impingement can develop over time and can be caused by leg Calvi-Perthes disease and slipped capital femoral epiphysis. There are two types of femoroacetabular impingement. A cam impingement where there is femoral neck thickening resulting to premature rubbing of the femoral neck during hip abduction. And there's also pincer impingement where there is a thickening of the acetabular rim, which also leads to premature rubbing. Femoroacetabular impingement, or FAI, can bring about pain when prolonged sitting, putting on socks, and during the mid-stance of gait, resulting to reduced mid-stance and quick weight transfer to the good leg. You can also have limitation of motion towards hip abduction and or adduction. This can also result to a noticeable locking or catching sensation within the joint. The assessment and joint mobilization treatment for FAI or hip impingement is the same, with an aim to reduce joint compression by providing joint distraction. First, observe the patient's gait and compare it to the other side, as patient will demonstrate reduced mid-stance or a quick weight transfer to the opposite lower extremity. After that, position the patient in supine with a tested or treated lower extremity off the table. The therapist will be on that side with both hands above the malleoli. From there, the hip is placed in 20 degrees of flexion, abduction, and slight lateral rotation. The therapist then pulls the leg by leaning backwards, then will compare it to the opposite side. If with noted difference in motion, then the therapist brings the hip up to the limit of the range and holds it for 3 reps for 30 seconds each. The therapist can also provide a high-velocity, low-amplitude thrust with a quick tug. Progress the mobilization to a lateral hip glide, where the patient is in supine with hip and knee at 45 degrees of flexion. You can also position your patient such that the hip and knee are flexed 90 degrees with the lower extremity over a traction stool. A mobilization belt is placed around the proximal thigh, and the therapist leans backward, then compares the hip joint mobility to the other side. If with noted limitation, the therapist can hold the position for 30 seconds each for 3 reps. Once the mobilization techniques were provided, the patient can be given open chain hip abduction and adduction active range of motion exercises for home to retain the motion, but do respect increasing pain levels. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Therani.